We're going to tackle the microcytic anemias in this lecture, and you're going to have to learn the nuances in each of the different diseases. I'm going to introduce a new advanced organizer which is going to help you remember the iron studies for each of the diseases, but then there's a lot of little details you have to know. Let's talk about how we get here. Someone presents with the signs and symptoms of anemia, or we check a CBC on routine lab tests, and we find that the hemoglobin is decreased. We know when we have anemia, the first thing we look at is the MCV, and for this discussion, we'll be in the microcytic category. Microcytic anemias are production anemias, so you can expect the reticulocyte count to be low. And if you have a microcytic anemia, the studies you're going to look at next to help you differentiate between them is going to be the iron studies. And if you have to pick only one test, and we'll talk about why, ferritin is the answer. The iron studies are ferritin, serum iron, total iron binding capacity, and the percent SAT. And this will allow you to separate the diagnosis into iron deficiency anemia, which, as the name implies, requires iron. Anemia of chronic inflammatory disease, which generally requires no treatment, but may get EPO, only in severe cases. Thalassemias, which will have two presentations and two treatments. Thalassemia minor requires nothing. Thalassemia major requires monthly transfusions, and therefore iron chelators. And lastly, we'll touch on sideroblastic anemia, which generally you don't have to know about. But I want to introduce, in addition to the algorithm, another advanced organizer that will help you understand the iron studies. This is the iron silo. A silo that stores iron. This silo is connected to a pipe with a valve the body can control. It stores iron in the marrow, and then when it needs more iron, it can open or close this valve to take iron out. This valve is variable, so the amount of iron that it drains from the stores can change. The amount that comes into your body is essentially fixed. It's about 3 to 4 grams per day. And no matter what you do, no matter how much iron you eat, you can only absorb a certain amount, at most 3 to 4 grams. Usually, 1 gram per day is replacement. The maximum that can be absorbed is 3 to 4. So the iron that's stored is called ferritin. The iron in the blood is called iron. The total remaining space that's left over in the iron silo that could potentially be iron, the total amount that could bind iron, is the total iron binding capacity. Now that doesn't make total sense just yet. It will in a minute. So we're going to use this advanced organizer as we talk about each of the different diseases. Let's start off with iron deficiency. In iron deficiency anemia, as the name implies, the pathology is deficiency in iron. This occurs in slow bleeds. This is not hemorrhage. If someone has a hemorrhage, they will not be microcytic. As the person is bleeding slowly, the body keeps up. It uses the iron and the iron stores. It opens up this valve and keeps draining the silo. Eventually, though, the silo becomes deplete, and as the person continues the slow bleed, the bone marrow cannot keep up. It is not an acute hemorrhage, it is in slow bleeds. And those are two patients. It is the old guy with colon cancer, the positive FOBT, or the young woman with menometrorrhagia. The diagnosis is made with the iron studies. The iron is low, the ferritin is low, and the TIBC is elevated. A bone marrow biopsy is definitive. The best test is a bone marrow biopsy, and it will show you that there is deficiency in iron. But don't do that because a bone marrow biopsy hurts and you can get the diagnosis just with some lab work. The treatment for iron deficiency anemia is to replace with iron. You're going to do this generally 324 milligrams 3 times a day. And because iron causes constipation, use stool softeners. All right. If we use this advanced organizer, the silo, I said it in words, now let's see what it looks like. Because that slow bleed, the body says, hey, I need more iron. So opens up the silo, opens up the valve, and all the iron starts to come out, and the body keeps up. But eventually, the iron silo gets depleted. The amount out of the silo increases. Remember, we have a maximum in that's preset. More out, the same in, eventually the silo depletes. The stored iron is ferritin, which is very low, and the TIBC increases as more space is made available. And because the iron stores are so low, it doesn't matter how open this valve is, there's not enough iron in the blood. Let's compare that to anemia of chronic inflammatory disease. The pathology here is inflammation. And I'm going to jump right to our silo. Our bodies are designed to fight infection. Bacteria cannot survive without iron. Our cells can for quite some time. So, in the acute setting, the body is going to disconnect the hose from the silo. The valve is tight, which prevents the bacteria from getting any iron. But if you've got a chronic inflammatory disease, the inflammation is around all the time, there's no infection to fight, but the same signal happens. So now the silo is disconnected from the hose, but you still have the same trickle in. Decrease out, same in, iron stores begin to fill up. And because the iron stores are filling up, the TIBC gets smaller. Now, if you said this to a hematologist, they'd laugh at you, right? Because in chronic inflammatory disease, the ferritin is elevated because ferritin is an inflammatory mediator, and there's inflammation. But this organizer helps you remember that in anemia of chronic inflammatory disease, the TIBC is decreased, the ferritin is increased, and because it's disconnected from the silo, the serum iron is low. So the diagnosis is made. The low iron, an elevated ferritin, and a decreased TIBC. Of course, you can get a bone marrow biopsy, but don't do that. That's cruel. You can diagnose it based on labs. And the person you're going to see this in is going to have chronic inflammatory disease, something autoimmune like lupus or rheumatoid arthritis. And the person, in regards to the anemia, is usually asymptomatic. And generally, the hemoglobin stays above 8, which is why the treatment is usually nothing. You generally do not need to intervene on these types of anemias, but in severe cases, you can use EPO, stimulating agents. But the thing is, what you'd rather do is control the disease with anti-inflammatories or disease-modifying agents rather than go after the anemia. Specifically, giving these patients iron will not do anything. You give iron to iron deficiency anemia, not to anemia of chronic inflammatory disease. Changing gears, let's talk about the thalassemias. The pathology of the thalassemias is that there is a problem with globin. That is, there is not a problem with heme. Iron deficiency anemia, anemia of chronic inflammatory disease were heme problems. Thalassemia is a globin problem. And you're going to see two types of patients. Minor patients who are asymptomatic and major patients who are transfusion dependent. In this case, the iron studies are going to be normal because it's a problem with globin, not with heme. The iron is normal, the ferritin is normal, the TIBC is normal. Let's explore this a little bit in more detail. You do not have to remember which genes are mutated or deleted. You don't have to remember what chromosome they're on. What you do need to know is how your patient is going to present. There are only 2 beta genes, but there are 4 alphas. So this is how the patients are going to present. If you only have 1 alpha deleted, the patient is going to be asymptomatic. They don't even know they have anemia. If you've got half of your alphas deleted, you will present with a mild anemia found on routine blood work, but will never get low enough to intervene on. The same is true with 1 beta deleted. If you have 3 genes deleted of the alpha, you have severe disease. You are transfusion dependent. The same is the case if you have 2 beta genes deleted. If you have all of your alphas deleted, you have hydrops fatalis, and you are never born. So let's see what this actually looks like. You never see 1 alpha deleted because they don't even know they have anemia. You don't see 4 gene deleted because they're dead. What you're left with is only mild and severe disease. Mild disease being a slightly low hemoglobin that never needs any workup, and severe disease being really bad anemia that requires constant transfusion. You make the diagnosis of a thalassemia when you see normal iron, normal ferritin, normal TIBC, and you get hemoglobin electrophoresis. How does the hemoglobin electrophoresis identify these anemias? Hemoglobin A1 is 2 alphas and 2 betas. This is hemoglobin A1. If you don't have enough betas for alpha to pair up with, alpha is going to pair up with something. And so you'll see different hemoglobins, the fetal hemoglobin or some weird ones. That is hemoglobin F and hemoglobin A2. So if you have a problem with beta, you'll see some other alphas. Thus, if you see some other alpha combos, you have beta thal. So hemoglobin electrophoresis can show you definitively beta thalassemia. If you don't have alpha, beta can't pair with anything else. So what you're going to see on the smear is normal. So you'll have a normal iron panel. Hemoglobin electrophoresis either shows beta thal definitively or alpha thal as a diagnosis of exclusion because the hemoglobin electrophoresis is normal. And as we discussed, there are 2 patients. The minors don't require any treatment. The majors require transfusions, often monthly. And because a single packed unit of red blood cells contains 350 grams of iron, enough for a year, and these patients are getting monthly transfusions, these patients can develop iron overload, hemosiderosis. You treat iron overload with medications that undo the iron from me. Deferoxamine, undo the iron from myself. The other medication is desaferox, but that doesn't have the clever name, so I'm going to continue to use deferoxamine. And be cautious here because you might be tempted to choose phlebotomy. Don't do that. You're transfusing them because they have low hemoglobins. The treatment for hemochromatosis in the liver lecture is phlebotomy. The treatment for hemosiderosis from transfusions is deferoxamine. Lastly, sideroblastic anemia. down here in the corner because you're not going to see it. If you are going to see this question, what you'll see is an elevated iron, and the other iron studies don't matter. Or it'll be a picture of a biopsy that shows ringed sideroblasts. So if you see a picture of a red blood cell, the red blood cell is there and it's got a dark circle in it, that's a ringed sideroblast, it's sideroblastic anemia. The reason that this comes up is because iron gets stuck in the mitochondria. Sideroblastic red blood cells are trying to make regular red blood cells, but the iron can't get out of the mitochondria, so the marrow throws more iron at them. The cells themselves are loaded with iron, just can't do anything. So when you measure the blood, the iron is elevated. And on the biopsy, you see the ringed sideroblasts. When you see a ringed sideroblast, the answer is sideroblastic anemia, and you're pretty much done. But to go one step further, for people going for 290, you have to separate this into reversible and irreversible causes. Reversible causes include drugs, alcohol, and lead. Irreversible causes include B6 deficiency, and you cannot correct it with B6, and myelodysplastic syndromes. And this is generally where it comes up. Someone has a myelodysplastic syndrome, they do a bone marrow biopsy to prove it, they see the ringed sideroblast, that's how you get sideroblastic anemia. Okay, this lecture had a lot of details that you have to know, so I want to run through it one more time. Iron deficiency anemia, look for colon cancer and menometrorrhagia, low ferritin, give them iron. Anemia of chronic inflammatory disease, asymptomatic anemia in someone who has an inflammatory disease, ferritin's elevated. Generally don't need to treat it, but can use EPO. The thalassemias are going to present either with minor or major. Minor is asymptomatic, major is transfusion dependent. The diagnosis is in normal iron studies because it is a problem with globin, not heme, so the silo will be normal. Diagnose thalassemia on hemoglobin electrophoresis. If you see beta thal and you've made a diagnosis of thalassemia, it's beta thal. If you've made the diagnosis of thalassemia and the hemoglobin electrophoresis is normal, it's alpha thal. Treat minor with nothing, major with transfusion, and when they get iron overloaded, use deferoxamine. Sideroblastic anemia, identify the ringed sideroblasts on the bone marrow biopsy. That's microcytic anemia.